is a diagnosis that no one wants to hear? Breast cancer. And this week, in a 5-part series called Inside the Fight, we're hoping to increase awareness, shedding light on the disease itself, and look at new treatments used in the fight against breast cancer. I sat down with Mayo Clinic oncologist Dr. Yadav to talk more about genetic research and precision medicine. Thanks for joining us tonight, Dr. Yadav. We appreciate it. So let's talk a little bit, let's specifically address genetics. How important is it in understanding someone's risk in the possibility of getting breast cancer?
Absolutely. So in the past, we knew that women who had family history of breast cancer were at a higher risk of developing breast cancer themselves. Over the last couple of decades, we have done research that have identified several genes, at least 12 now, that are associated with increased risk of breast cancer. Some of these genes, in fact, increase the risk of breast cancer by almost 4 or 5-fold, which is quite high if you think about, compared to average women who are at risk of developing breast cancer.
That is amazing. So when is that detected, and how soon should people be tested for that? Is it something that we can preemptively strike against breast cancer, getting it, or even the early treatment of breast cancer?
Absolutely. One of the areas that we are now focused on is early identification of women who are at high risk of developing breast cancer. One of the things that women should think about is, especially if they have a family history of breast cancer, they should talk to their doctors about whether they should get genetic screening or not. Mm-hmm. All women over the age of 35, regardless of their family history, should talk to their doctors about their risk of breast cancer, what we call as breast cancer risk assessment. This should be done in every woman who is over the age of 35.
So now, when we talk about the early detection, I know that there's a BRCA gene that can be tested. Is that something primarily women who have a genetic history, or do you advise someone to say to their doctor, regardless, I don't have anybody in my family, but it's something I still would like to do, just to be preventative?
That's a great question. I think more so we are increasingly moving towards that, but we are not there yet. Mm-hmm. Right now, the genetic testing is still available to women who have a family history or who are considered to be high risk based on some of these risk assessment tools that we utilize. It's not yet available to all women, irrespective of their family history. But increasingly, the restrictions towards genetic testing is going away, and more so, we're testing more and more women and identifying that a lot of women who test positive for BRCA1/2 or other genes do not actually have a family history. So this is something that we are still learning, and we are making progress in this area.
Is that where we talk about precision medicine then? Because I know that's one of your areas of expertise. Let's talk a little bit more about that for folks, viewers who might not be aware of what it is.
Yeah, I think we have always known that all of us are very unique, right? Our DNA code is very different. Everyone has unique DNA code. How we react to certain treatments is very different based on our DNA code as well. This is what we call as pharmacogenomics, meaning drugs, the same drug may have different effect on different individuals. The second thing that we look at is tumors are very different as well. When we talk about breast cancer, we're not talking about one disease in some sense. Mm-hmm. Every tumor is unique. Our goal right now is to sort of identify right drug based on patient characteristics, but also based on tumor characteristics. And this is the field of precision oncology. We have tried to do this for the last several decades. It's only more recently that we have the tools to accurately understand what are the risk factors within the tumor and within a patient that would predict response to a certain drug.
How do you target then specific treatments? Where does that come in to play with each patient?
Yeah, so I think the first step is identification of what are the alterations that are present in their tumor or their germline, meaning that some of the alterations that they were born with. And then, obviously, there are newer drugs that are now in the pipelines, and some of them have already been FDA approved. This is where a lot of research over the last decade on targeted therapies and immunotherapies have been very successful. In breast cancer world, just within the last 5 years, I would say there have been several drugs that have been approved that are very specific targets based on genetic alterations. I do not consider myself old. I've been practicing for 7 years only. But within 7 years, I have seen a significant shift in how we treat breast cancer, and it's amazing, and it's good news for our patients.